So I'll request Dr. Gopal Pillai, who is, now a very senior ophthalmologist in Cochin, to tell us about what are Gopal unmet needs in DME.
Thank you very much, sir. Today I'll be speaking on understanding the medical unmet needs in diabetic macular edema. And this is my disclaimer. We would be browsing through the disease burden, and I'll be dividing the unmet needs from various perspectives. The most important perspective is the patient's perspective, and then the physician's perspective, and the healthcare system perspective, because healthcare is also what divides all those things. And then I'll summarize it. So what is a disease burden? All over the world, diabetes is a major problem, a menace. It is growing, right from North America to South and Central America to Middle East, Europe. Everywhere you see it is increasing, and Southeast Asia is no exception. And India also, there is a significant number. India houses about 1/5 of the world's diabetic population. And if you look at all the diabetics put together, about 40% of them will have some quantity of diabetic retinopathy. 17% may have proliferative diabetic retinopathy. 19% will have sight-threatening diabetic retinopathy. The diabetic macular edema is about 9.1%. The difference between proliferative diabetic retinopathy, which will potentially blind vision if not treated, versus diabetic macular edema, which reduces vision but will not create blindness. But what happens is, in that age where economy, financial gaining is important, your decrease of vision will actually put them out of the job. That is a major problem. But if you look at treatment in India, mean number of injections received is about 2 per year. That's a very, very low figure. You know why? 2/3 of patients drop out from therapy within 1 year. Most patients receive suboptimal treatment because many of them are paying from their own pockets, and some of the patients do not have bystanders to come with them each time. And some people say that vision did not improve at all, and that is why should I re-inject? So these are the percentage of injection, but what you should know is approximately we will get only 2 injections per year for diabetic macular edema. Now, there was a survey by Indian retina specialists to understand the DME management perspectives, and demonstrated that any fluid on OCT is a very, very important paramount factor for disease activity. Identifying importance of drying in the retina is very important, and injection frequency is a very important thing for non-compliance. 45% of the physicians felt the need to reduce the treatment burden and highlighted the need for more durability of treatment. Now, as I said, we will look at it from different perspectives. What is a patient's perspective? Always diabetic macular edema patients will have multiple problems. They have a lot of comorbidities, including stroke, cardiovascular disease, amputated neuropathy, retinopathy, nephropathy, all these are there. And he will have to spend time, effort, and money in all these problems. So, no wonder that the quality of life is very poor in these patients with diabetic macular edema. Patients and caregivers, they had to take time off the work schedule because injections won't stop. In protocol I of the drcr.net, they were talking about 9 injections in the first year, and you will require to follow up these patients every monthly, and that is why it will take a lot of the working time. About 4.5 hours is the time that they have to spend in the hospital. 53% of them are working patients, and 71% of them require a caregiver to come with them. And the caregiver will lose 1 day's salary or job, and because they are all employed, and those are some of the problems of the caregivers and the patients. Now, when you compare AMD with DME, in wet AMD patients, since we also counsel them that if you lose injections, you may lose vision very rapidly, their follow-ups are more better. Whereas in diabetic macular edema, a huge number of patients who do not show at all. And treatment compliance is DME is very low, even in the global, even in India. So that is one unmet need which is there from the patient side. So long waiting hours in the clinic, other problems like amputation or renal failure, all those things will contribute to barriers to follow up. So treatment compliance directly affects visual acuity gains in patients with DME. And we know that real world evidence shows poor visual outcomes with lesser number of injections. That is known all over the world. To summarize, patients have multiple comorbidities, And because of these and caregivers and their time and the perception that vision is not improving, they usually lose to follow up. Now, what is a physician's perspective? Physician basically identify reduction treatment burden as an unmet need. If we were able to treat somebody with lesser number of injection, which means that there is a long duration of action, then they feel that the patients will be more compliant. So they identified improved efficacy and safety as major unmet needs. So efficacy has to increase, durability has to increase, which will result in reduced number of injection. So that is the key to a physician's perspective. What about healthcare system? Healthcare system requires a management of comorbidities, monitoring these patients, increase healthcare utilization and treatment burden. You can see that significantly higher healthcare resource utilization in DME patients are there compared to non-DME patients. And so treatment of DME confers substantial burden on patients and healthcare systems because of frequent healthcare visits, frequent monitoring with OCT, and transportation assistance with people who have amputated foot or other problems, etc. So there are a lot of administrative challenges and clinical challenges in the health perspective, which we directly as ophthalmologists are not involved, but policymakers will be significantly involved there. So again, because of this multifactorial reason, there is a lot of problems with this. So disease burden, patient comorbidities, non-compliance and under-treatment, increased healthcare resource utilization, and suboptimal visual gains. These are the problems and unmet needs, and these obstacles, which are key obstacles, needs to be overcome. Thank you very much.
Thank you, Gopal, for dividing your talk into patient, doctor, and healthcare system perspective. But believe me, central to all this is the duration and durability. You can come and join me here. So, believe me, ultimately, we are all looking for increased duration of injection and durability. I'm not very sure whether physician wants a reduced treatment burden. Patient definitely wants a reduced treatment burden. Physician may want, patient to keep visiting the hospital. Although Gopal, through his 2 slides, said that physician ka unmet need also is the frequent visits. But believe me, it is more about the patient's quality, patient's relatives, finding out that 4.5 hours time. They are more concerned. And the compliance is less primarily because of the comorbidities, because each diabetic has to visit at least 4 places, neuro, kidney, and then, endocrinologist, and then eye care system also. So that is one reason all of us are looking for a method or a injection or something so that this unmet need of the patient, I think primarily of the patient only, is fulfilled by reduced frequency of injection and reduced visits. Believe me, it is not only visit which matters, ultimately the whole financial system of the family suffers because patient does not go alone, he has one relative along with him, then he has to travel, then get the investigation done, then treatment done. And if you multiply this by the number of visits in a year, this becomes a huge treatment burden. No, Gopal?
Absolutely, sir. So when efficacy increases, durability increases, and safety increases, there is a significant number of patients will find that coming to a doctor for treatment is very, very fruitful. Currently, what happens is that since the efficacy is a little lower, which means that each injection, the edema may reduce by about 10%, or the vision may increase by maybe 1 letter, 2 letters, that the patient does not perceive as a very good result. So when the patient perceives it's a good result, there's an impetus for the patient to visit the physician again and again.
So may I ask Niaz, good friend of mine from Bangladesh, what is, you can be on the mic. Yeah. Say it again. Eco.
Yeah, what's the question, sir?
Yeah. What we wanted to know from you is what is your approach considering the reducing the treatment burden for the patient?
Yes, that is very important, reducing the treatment burden. But with also reducing treatment burden, the patient also can neglect coming back. So there has to be a compromise between the two. There has to be a communication between the patient and the center so that we can call the patient in. But reducing treatment burden is obviously very important because at the end, cost is a very big factor, and that sort of determines patient compliance as well.
No, key question, how do you counsel a patient? Suppose you have identified center involving DME. What do you tell him and how do you counsel him that, you are giving an injection and how much frequency he will have to visit? What injection is your choice? What is your choice of injection in the first go?
Depending upon actually, injection of now, as the newer drugs are coming in, we are finding that the newer drugs are more effective than the older drug. The amount of, the macular edema reduces much quickly with the newer drugs like brolucizumab and faricimab than Avastin and all. So, but the thing is, there is a cost factor involved. So we have to individualize the patient's financial condition and what they can afford. So that is, I think, a very big factor, what the patient can afford, because in our country there is no health insurance and everything is out of pocket. So that is very, very important.
Yeah, this is a very important point you raised, because wherever there is health insurance, patient is not paying from his pocket, it does not matter much. But wherever patient has to pay a pocket, then what Gopal Pillai, initiated as unmet needs from patient point of view, it becomes very, very salient. So Matthew, what is your take home about the choice? Thank you, Niyaz. Can we have one floating mic? Because we have so many injections now available, are you looking at increased duration of action or anything else?
I think we see both the parts, like it should be durable and it should be efficacious as well. So I think the aflibercept and the newer anti-VEGF rolizumab comes in a first choice in treating DME as an first line choice.
Okay. I think with this small discussion, we will move on because we have only 1 hour. You see, most of us, check the vision of the patient in the first go. But what I would like Ramesh to tell us is that on OCT, you see, whenever a patient comes of DME, we take his vision, refraction, best corrected visual acuity, and then jump to OCT. Can OCT guide us, Ramesh, to treat this diabetic macular edema irrespective of the visual acuity? You see, poor vision, we always do it. But can OCT markers guide the physician in the management?
So thank